If everyone would take their seats, it's about time to get started. Wait on Mr. Parrish there. Okay. This is the meeting of the Special Committee on Access to Quality Health Care. This past week we had a 3-hour hearing where various organizations could make their pitch either yay or nay on this particular issue, House Bill 198. We've got two other groups who from rural Georgia that were not able to make it, and I've told them that if nothing else, we're going to be fair and let everybody be heard who wants to be heard. So we'll start off with the first hearing group on this. Chris Dorman from Tiff Regional Medical Center. Are you here? Okay. And this will be operated the same way it was done during the regular hearing. It will be each group will have 10 minutes, and then once this is completed, then Chairman Hatchett will go over the changes that were in the original bill, so that between now and Monday morning, just so y'all know, Monday morning, 8 o'clock, right here. Another meeting, probably won't last but about 10 to 15 minutes. But I want to make this statement. I'm going to make it now, and I'll make it at the end of the meeting, and I'll make it on the House floor. Any member of this committee who is not here Monday morning at 8 o'clock to vote on this bill will be taken off the committee. Just want you to know this. Any member who's not, unless you have a really good excuse, and I want to emphasize the really, unless you've got a really good excuse, if you're not here Monday morning, you will be removed from this committee. Okay, Chris Dorman from Tiff Regional Medical Center, it's all yours.
Thank you, Mr. Chairman. Good morning, Mr. Chairman, members of the committee. I'm Chris Dorman. I serve as the President and CEO of Tiff Regional Health System in Tifton, Georgia. Also a phlebotomist and a nighttime patient transporter and anything else that's needed as a rural CEO. So I want to talk to you guys a little bit about competition. We have all heard the talks of competition and how competition drives better outcomes and ultimately lower costs. And I agree with this logic, and I'm a fan of competition. As an athlete, a scientist, a farmer, an entrepreneur, I've always enjoyed learning from my competitors and believe that my performance improved because I had competition. However, competition in healthcare is a bit different than competition in other industries. Competing athletes challenge each other to become faster, stronger, and ultimately better. But what happens when the rules of the competition are not applied to both athletes? Imagine a competition between similar athletes, but one athlete is required to compete with these conditions. He cannot sleep for 7 days prior to the competition. He must compete with 67-pound weights on his ankles. He must reach a goal line 50 yards further than his competitor. Now take the other athlete, fully rested, not burdened with additional weights, with shorter distance between the starting line and his goal line. Who will win this competition? Actually, is this really a competition? With these added burdens, the first athlete fails at the starting line. The event never starts. This analogy may seem odd and perhaps dramatic, but this is what House Bill 198 will do to rural hospitals in Georgia. House Bill 198 will burden rural hospitals to the extent that success for us, like the athlete, will not be an option when we are too burdened to leave the starting line. As a rural regional referral center, Tift Regional Health System supports our 12-county rural community with over $67 million in indigent and charity care, also providing high-quality care to several of the sickest communities in our state. When you think of rural health care, most will be shocked to know of the advanced services we provide to rural Georgia, providing advanced life-saving care such as interventional cardiology, endovascular intervention, radiation oncology, among others, requires a large catchment area from which specialists may draw patients. In rural Georgia, these specialized services simply cannot be sustained by the population even with a 50-mile radius of a hospital. Additionally, these services can't be staffed with only one physician. No physician can cover a hospital service 24 hours a day, 7 days a week. These gaps in coverage are often supplemented with expensive locum tenens physicians that typically cost 50 to even 80% more than a traditional physician relationship. Nonetheless, we are providing these services and are constantly striving to do more. Despite the inherent burdens of a rural hospital, sparse populations with substantial percentage of indigent and low-income residents with significant health care needs. When we discuss the service area, the proposed 10-mile radius is not even enough to cover the county in which we are located, not to mention the broad areas of support that would be compromised by such an unbearable mileage radius. To take care of these populations, patients originating from a large geographic area are required. We are investing in our community. Cook Medical Center facility is about a $50 million project that will open later this fall. We are currently evaluating whether we can expand services in Cook County to include an emergency department. This expansion will increase construction and equipment costs and will require the services of not less than 4 full-time physicians, along with nurses and support personnel and round-the-clock diagnostic staff. To comply with the federal laws of EMTALA, we will also have to make on-call physicians available to respond to emergencies around the clock. With House Bill 198, our evaluation of the Cook ED and the expansion of services in general is stalling. With House Bill 198, we, like the first athlete, will have the burden that will not be imposed on others. The population in Cook County, Georgia simply does not support the costs that would be incurred in the operation of an emergency department in compliance with the state law and EMTALA. However, ambulatory surgery centers, like the unburdened athlete in my analogy under House Bill 198, would not be so burdened. An ASC could locate 10 miles north of this new Cook facility, and like the unburdened athlete, its staff could perform elective surgeries all day for selected insured patients, close up at 5 p.m., return to their homes, and come back rested the next morning. In this scenario, our new Cook facility will not be able to leave the starting line. We're not here to complain about the inherent burdens on rural hospitals. We are here to tell you clearly that we cannot provide the services we provide if the rules are changed such that facilities who compete by providing services without these same burdens are allowed to enter the service area that support rural hospitals. Rural hospitals must be able to serve a large geographic area to fund these expenses. 10 miles in rural Georgia is not 10 miles in Atlanta. In conclusion, competition is very good. House Bill 198 will not promote competition. House Bill 198 promotes the elimination of competition, ultimately the elimination of rural hospitals. Thank you.
Does anyone on the committee have a question for the presenter? Okay, very good. Thank you. Thank you, sir. Okay. Mo Yerta? This is the Colquitt Regional Medical Center. We'll have 3 presenters, but they all realize it's a total time of 10.
Good morning, committee. Good morning, Mr. Chairman. I want to thank you, first of all, for your focus on rural health care and bringing your concerns to the forefront of legislative discussion. You've really poked a hornet's nest, but it needed to be poked, and you've got a good reaction, and that's why we're here today. My name is Dr. Maureen Yerda, and I began my association with our rural community hospital 6 years ago when I was still assistant superintendent of the Colquitt County school system. It is indeed my pleasure and with great pride to tell you about Colquitt Regional Medical Center in Moultrie, South Georgia. It is an exceptional rural hospital that is successfully providing access to health care throughout the community and surrounding area at a low cost and at a level of quality and safety that is recognized nationally. As chairman of the Hospital Authority, I can attest to the importance of our hospital as a leader in rural health care, that focuses on your concerns of cost, quality, and access. The hospital does this by focusing on the delivery of exceptional care by exceptional people. With only a 1.6% margin and an indigent charity care cost of over $9 million, our hospital provides services that positively impact our community health, such as, just to give you a random laundry list, we have 99 beds with over 1,200 employees. In a county, it's the largest employer of full-time work. 24 specialists, with 12 new physicians recruited in the last year, young, vibrant physicians. We've screened for breast cancer in over 4,000 women. A clinic in Norman Park that averages 35 patients a day in peak season. We provide health care for our county employees. We've saved the county over $1 million in revenue by providing the health care for the county employees. We provide health care for the jail and prison system. We provide prenatal and OB/GYN care to migrant workers at the Ellington Clinic. The Vereen Rehabilitation Center trains physical therapists to serve as athletic trainers at 9 schools in South Georgia, at no cost to the schools, but at a cost of $300,000 to the hospital. Thanks to your rural tax credit initiative, our hospital had 381 new donors making a gift of $5,000 or more. This has enabled us to create an oncology center to provide treatment and support for our patients that previously would have had to have the burden of driving 30 or even 50 miles, sometimes every day, 4 or 5 times a week. We continue to seek ways to expand our services to our community, and future plans include extending the oncology care to include radiation therapy so that our patients do not have to travel to receive treatment, and developing an educational center for continuing education for our medical staff so we stay at the top of our game, and residency education for resident nurses and family practice residents. Colquitt Regional Medical Center is committed to supporting healthcare education for rural practice. So we want to come to you from a different perspective and let you know that some things are working. Some things in rural healthcare are working and achieving the objectives you want to achieve. We want to be partners with you in possibly modifying the CON and address the issues that most concern you. Colquitt regionally and our staff are willing to do the research, to crunch the data, to find out why it works in Colquitt County while other rural counties are struggling with healthcare costs and access. We are succeeding at what you want to achieve, and we want to preserve our progress forward. We are here today to ask that you contemplate upon what is working in Colquitt County, ensure that the work we have begun and the future we plan for our community is not impaired by new rules and policies. We're asking for your consideration of some type of protection or possible exemption so that we can continue our work in effective rural health care. With me this morning are 2 of our finest. I'm proud to introduce Dr. Michael Brown, pulmonologist, critical care physician, and director of quality, and Dr. Justin Baker, family practice medicine physician and current chief of staff. Doctors Brown and Baker have a passion for rural health care and a commitment to our community. They want to share with you how they see the investment that Colquitt County Regional Medical Center has made to improving lives and the health in Colquitt County.
Thank you, Matt. Good morning. First, I want to echo your sentiments. I want to thank you for your hard work towards the betterment of our great state. We know how much time that you spend away from your families, your jobs, and other responsibilities to be here and represent your districts. We appreciate the opportunity to represent our community. Our medical community has a passion towards providing high-quality care for our rural Southwest Georgia community. Leapfrog, a national rating system for quality care, has given our institution the highest grade A rating 9 consecutive times. Governed by a rotating local authority, the gains of our healthcare system remain focused on improving the needs of our community. We have answered your call for rural health initiatives like no other. Our community has led the way in becoming one of the few rural healthcare entities with a family medicine program, and 2 physicians in our first graduating class this year will practice medicine in Moultrie. Due to outstanding public service among several citizens in our area, we will also have a medical school starting this fall, with some of our first-year students coming from the region. These initiatives towards self-reliance extend to nursing scholarships, loan repayments, and other programs designed to provide our populace with the skills and knowledge to ensure care for the next generation. Medical staff members in our community provide coverage for indigent patients. We ensure coverage for our jail population. In contracted service with our county government employees, we have saved local taxpayers over $1 million per year. And again, as a nonprofit organization, the revenue of our facility remains centered on and for our community. Last year, we provided $7.8 million in hardships and indigent care, with bad debt over $32 million. Yet, despite our current viability, our healthcare system revolves around maintaining a small profit margin. Private insurers only represent 21% of our patient population. Over 10% have no insurance whatsoever. We understand that the existing state laws warrant change, but certain provisions protect our community-based healthcare system from threats, such as ambulatory surgery centers, particularly multidisciplinary, and various diagnostic centers, especially where a viable option for similar care already exists in the region. These entities would not have the emergency department or inpatient facilities to require to provide health care for every uninsured or underinsured patient in our community. Neither would these entities care for higher risk patients, and thus are able to choose only profitable patients, leaving our true and complete healthcare system financially vulnerable. I will add that myself and many physicians I know would rather utilize a hospital system for themselves and their families in lieu of an ambulatory surgery center for a given procedure. Lacking emergency services or additional staffing, in the event of an adverse event, the ambulatory surgery center themselves would simply call 911, wait for an ambulance to arrive at the facility. They would pick up the patient, and then they would carry them to the nearest emergency department. There would be no continuation of care at that point. There would be no peer reviews. There would be no case conferences that would be the standard operating procedures that exist in our healthcare system. They would simply move on to the next profitable case. The implication that ASCs improve quality of care is misleading. We believe in fair competition, and we believe in ensuring access to our community. This is not about personal gain for us. Most of our physicians are from the rural South. I myself grew up in Tolliver County. I now work in Colquitt County, and my kids, like Dr. Baker's here, go to public school. Our success is intertwined with the success of our community. We want to help in any way possible in this decision-making process, and we are available to you. And with that, I now turn it over to my friend and my colleague, Dr. Baker.
How are y'all today? I'm going to echo some of the same sentiment that Dr. Brown did and Dr. Yerda did, just in thanking all of you for your work and for your time. We know this is a difficult subject. We know this is something that gets everybody heated in one way or another, and we appreciate that people are willing to tackle such difficult things. Right now, I'm the chief of staff at our hospital. I've been the chief of staff for the last 2 years. I've been in Moultrie for the last 10 years. I'm from South Georgia. I grew up in Valdosta. I wanted to be a physician since I was a small child, to be honest with you. One of the things that I see and that I'm proud of at our hospital is the care that we give to the patients in our hospital. I don't think that you could find a better one. I think the Leapfrog Awards speaks to that. I'm very proud of our medical staff. We have a very united medical staff. It's not something that you see in a lot of hospitals and a lot of hospital systems. Our medical staff bands together. We get along. We actually get along with our administration. Our medical staff all feel that this bill could be very threatening to our community. I mean, yes, we worry about the hospital. I mean, we do. We worry about how the hospital can perform and how it can survive. But we also worry a lot about our community itself. You heard them talk about the different programs that our hospital has created, programs that they run in the community, programs that are essentially losses for the hospital, but it provides for the health of the people in our community. It provides for the health of the people who really cannot pay for it themselves, people who don't have insurance in a lot of ways. We worry about the types of patients that we'll start seeing. If our hospital is having to take care of only the sickest, having to take care of only the patients that have little income, have little insurance, and then are also taking care of the patients who have complications, who have problems with surgeries that are done in some of these surgery centers. We've seen patients, I know of one example where a patient had a spinal surgery in an ambulatory surgery center nearby. They had a complication from the surgery. They had a bleed into their spine, which developed into an abscess. That person was not seen at the surgery center again. They were told by their surgeon, you need to go to your nearest ER. Well, the nearest ER was us. They came to our hospital, they were taken care of, and they were in the hospital for weeks while they were being seen and managed. And they weren't seen again by their physician at this ambulatory surgery center. These are the types of things that we worry about. You could say the same sort of thing for the radiology centers. There's not a lot of complications, I guess you can say, coming out of radiology centers, but the thing that you'd worry about is just the quality of the images that you obtain. It's not uncommon for them to stop developing and stop improving the technology that they use because it's just costly. So when they have scans, CT scans, MRIs, ultrasounds, those things done at these radiology centers, they come to our hospital. We don't have access to them. We end up having to repeat a lot of these procedures and a lot of these scans because, one, we don't have access, two, the scans may not be of high quality. And that has happened multiple times. We know that the CON has to change in a way. I mean, this has been the way it has been for a long time, and there are many ways it's not working. We understand, especially up north of Macon, it's not working very well, and there's things that you all want to change. We understand that. We also understand that there are very good things about the changes that you have talked about. We don't have any issue with transparency. Transparency seems like a good thing. Thank you. We think that we like the idea of there being a cheaper, easier process for things to be done in hospitals and things to be done in communities. We think it's better for hospitals to be able to expand their beds and expand the services they offer without having to go through a costly process. So we know that there are things that need to change. We just are asking that we can be part of that process. We're asking that you can come down to Moultrie, honestly, if you want to. You can come to Moultrie, see what we're doing. Like Dr. Yerta said, we're willing to crunch the numbers. We're willing to look at the things that we do properly to try to help other rural communities and maybe bring about better change for our healthcare in our state. Thank you. Any questions?
Thank you, sir. Yes, we have several questions. Chairman Cooper.
Thank you very much, Mr. Chairman. I have a master's degree in nursing. My husband was a family physician. And I tend to always work and support my physicians. I appreciate the head of the hospital board being a little more positive. Are you employed by the hospital? Are both of you employed by the hospital?
Yes,
ma'am. All right. So I felt like the attack on ASCs is unwarranted. It is not supported by the research across our country about ASCs. They're not hotbeds of emergencies and bad care from physicians that work them. So I think that I would appreciate it next time if you would look at the research, and certainly they offer a less expensive, often, method. They get paid less than you do. If they have bad debt, they do not go into our indigent trust fund. There are a lot of things that, put them at a disadvantage. But they put them at the advantage of patients who like the fact that they don't have to go into a hospital where they may get MRSA or staph and be exposed to it. They like the convenience, and I have trouble with other doctors despairing the doctors that run them just automatically. Now, I chaired this committee about 8 or 9 years ago when we opened it up a little bit. I still have the scars, okay? And we at that time said, your hospital may be running fine, but it's not everywhere else. And we said at the time that maybe what you need to do is partner with those doctors that are not hospital-based. Open up a multi-specialty surgery center together and, help meet those doctors that don't want to be hospital-based. So I hate to beat up on you, and I'm proud of Moultrie. It's a beautiful little city. If I had to live in the South, that'd be one of my choices. Very proud that the medical school is coming there. I'm very proud of what you're doing, but that's not happening all over. I used as an example recently, there's a little hospital that bought where you can do robot surgery. It sits empty about 3 days a week, and it was very expensive, and this little hospital is struggling. They had a consultant that came in and said, you got another little hospital over here. They would love to use that, machine when you're not using it. Do you think they would work together? Absolutely not, which would have helped both hospitals. So your instance is not the same as other, but I just have a little trouble when one set of doctors starts attacking the other doctors, and it's not scientifically based. And I'm sorry to pull you on the spot. I appreciate you growing up in Georgia and working here. We need the doctors. I appreciate what you do for patients, but if you're going to do that, you better come armed with a lot of the research from across our country that proves what you're saying is right. Thank you, Mr. Chair.
Could I just
Yes.
make an answering point? And I value your comments, and obviously you've worked very hard on this, and you probably still do have the scars. They were only talking from their personal experience with ambulatory centers. That's what we tried to do this morning, is give you a personal experience in Colquitt County. We can't speak to all ambulatory centers.
There's a lot of mistakes and a lot of
Correct.
that goes on in hospitals.
Correct,
Right.
correct. And so what we're saying is in our hospital it's working, and this is our experience. That's all we wanted to share.
May I speak? I'm not meaning to disparage other physicians, and I'm not meaning to disparage, but my concern is our hospital, because it is the center of our community. And my fear is that I'm worried about the patient that comes in with pneumonia, that comes in with COPD, and being able to support that patient. And what we have found is that when ambulatory centers come up, that all of a sudden your community needs twice as much of a procedure. And the risk that you had mentioned about infections is really not the case at our facility. When there is the areas in which we do outpatient-like procedures, they're not done in the same places that are done in the inpatient realm. So, and when we do have infections, we usually find it's because we had a problem with it because of a high-risk patient that we took that an ambulatory center wouldn't do. What we're concerned about is losing a hospital. The hospital that takes care of patients at night, that takes care of patients at weekends, and that was our fear.
First of all, Mr. Chairman,
Yes,
first
ma'am.
of all, hospitals don't take care of patients. Physicians take care of patients. Hospitals don't exist without that. And I understand your passion for your hospital, but this in your passion and your success, we are not hearing from all the other places or the type of working for it. So, I understand the plea for your hospital. I understand that. But the other thing about it is we have been trying to bring about some CON changes for several years now, and it's had to come to this. And now you're saying, okay, we're ready to work with you. When we asked people to come forward to help us for other changes, it was no, 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 and hell no. Pardon my expression. And so now when we have gone all over the state to rural areas, 2 years, talking to other things, and we put forth a bill, then all of a sudden everybody is really willing to help us, and what that sounds like is major delay tactics. And, let's just put it off, let's don't do anything. I mean, like I say, I've been through this before. I know what the hospitals did then. We are trying to help you and do the very best we can, but we've had no cooperation for the past 10 years since we did it, until some really brave people decided they would go after this again. And so glad I'm not the chairman, I'm just the vice chairman this time. So sorry to go after you, but I'm very protective of physicians across our state. I know what they do on both issues, and I get a little tired of, hospitals saying they treat patients. And many of our places, it's the doctors who come and cover those emergency room physicians, the independent doctors, and they don't get paid when they stay up all night. And they, and if the patient doesn't pay, the hospital can go into the Indigent Trust Fund and get some of that money back. The surgeon who did that, the independent surgeon, stayed up all night, did the surgery, he doesn't get a penny in many of our hospitals across our state. So I'll have a little trouble when you start with that. And my husband didn't own he was a GP, an Emory-trained GP. So we didn't have a dog in that fight, but anyway, I'm sorry. I'm sorry, Mr. Chairman.
Can I make one?
Okay, let's stop, because we've got at least 5 more questions that we need to have answered. That was another 10-minute dissertation. All right, Chairman Reinders.
Thank you, Mr. Chairman, and thank you all for driving up to talk with us. I represented Colquitt County for several years and just think the world of Dr. Adcock.
Yeah, absolutely.
The other gentleman from TIF Regional was kind enough to let us know that he represented 12 counties in his region. How many do you have?
How many counties do we have?
Yeah, in your do you have a Colquitt Regional? How many?
We represent, our county as well as, we don't have, they're surrounding counties, but we do not have businesses outside.
No, your service areas?
Yeah, we don't have,
Not outside of Colquitt County.
And I'm going to go down a path that's one of my niches. I appreciate the word community. I truly do.
And that's, that's what we're here to represent is the
So is that
community.
Moultrie community?
No, it's the whole Colquitt County. It's like at Norman Park and Ellington and Omega and Doran, all the small communities. But only one county.
Only one county. Okay.
But we take care of patients, obviously, in the region.
Now I'm confused. Is it one
We
county or
don't- I have patients
is it one county or
I
the
have
region?
patients in my clinic that come from Fitzgerald, Georgia, that are an hour and 15 minutes away. I have patients that come from, Cook County, Mitchell County.
But there are no established
but there are-
clinics outside of our county.
Right. This is a little pet peeve of mine, and that is where the hospitals are located that talk about community and what they do to help their county with the jail population. I think you mentioned 9 schools. And we hear from the counties outside of you that take their patients and go, but they don't take care of our jails.
I'm sorry?
They don't take care of our jail population. Or they don't help us with our schools. Do you take...
The schools are outside Colquitt County.
I'm sorry?
The schools are outside Colquitt County.
The 9 schools are outside.
The ones that we send athletic trainers to from our Berean Rehabilitation Center.
And again, that's kind of my point. I appreciate, because that's the first time I've heard that. And I'm so grateful for that. I think that part of that access, because I think the phrase, not have to travel to seek treatment, was one that y'all made. And so I just hear from communities, we heard from it last week in Macon, where they're helping jail populations and they're helping this, but they're not doing it in the outlying area that they take their customers from. So I would just be hopeful that what you would do is look at your own model and say, you know what, if we're giving a tax benefit here or a jail population, and I'm not saying 100%, I don't know, but are you proactive enough that you actually reach out to
Other facilities.
to Cook County and say, how can we help you with your jail population, hypothetically?
When we do our physician strategic meetings, that's exactly what we talk about, is how can we integrate with and how can we work
So
with
has
other
Cook County
surrounding
said no to
hospitals.
offering helping with their jail population?
I don't know that anybody has asked them.
And that's my point.
Okay. That's
It's
a good
not,
point.
to me, the community isn't just where the hospital happens to be located.
It's their surrounding
But
areas.
if you're going to take patients from the surrounding area, which is, and I understand the revenue stream argument, I don't want to leave you without one. I get that, but I would just hope that your outreach would be greater than just your board of directors who all live in one central location for all hospitals. Thank you.
Yes, sir. Thank you.
Okay, Chairman Nix.
Thank you, Mr. Chairman. Let me first say I am not a doctor, and I am not a nurse, and I'm not going to lecture you. I'm appalled that some of the people in this room who say they want to improve care in rural Georgia would disparage a single word that you say. I am actually appalled at that. I love your passion for your community. I love the fact that you live in your community, that you love your community, that you serve your community, and you want to preserve the good work you've done. And I applaud you and thank you for coming and putting that word out to this group. Thank you very, very, very much.
Thank you, sir.
Thank you.
Representative Jones.
Good morning.
Morning.
How you doing?
Yes, sir.
Well, first of all, I knew Colquitt County did high school football very well, but I did not know how well you did medical care. I know you're saying that you need to crunch the data. I'll be honest with you, I wish you would have crunched the data just because I tend to think that way. But empirically speaking, if you were to share just one best practice, because I know the chairman wants to move this along, what would be that best practice? Because it seems to me we have what could best be described as a gulf between we hear your testimony and to Chairman Nix's point, you know, everything that you want to hear from, I'll say, the rural hospitals in terms of community health care, et cetera, and then we hear others talk, let's just say, about the challenges that they're having. So if you could share with them, what would be that one best practice? Notwithstanding, I still would love to see the data, but what would be that one best practice?
I really think it has to do, people, yeah. I really think it has to do with vision. So the board has a vision of where they want to be and how, and sustaining a community hospital, they work well together. Our CEO has a vision that involves divergent thinking and thinking of options, you know, so it's working where that vision becomes something that we work on every day. And that vision has enabled us to draw in incredible physicians who then in turn around and recruit other physicians. So it's having that focus on where do we want to be next year, 5 years, 10 years, and how does it impact on our community. We had a strategic planning meeting just a couple of weeks ago, and we're talking about, the board and the MEC are talking about 20 years from now, where do we want to be? What other service lines do we want to produce? And how far do we want to stretch out without encompassing, you know, getting too competitive and taking somebody else's market, but how can we profit? But I think it comes down to that vision and sense of purpose that this is what we're about and we're going to do it well.
Great culture.
Exactly.
Okay, thank you.
Representative Newton.
Thank you, Mr. Chairman. I do appreciate y'all being here in the earlier group from TIFT. I do think the passion in many of our rural hospitals and the strength of them is impressive. I did want to clarify one point about the ASCs that Chairman Cooper may have brought up. My understanding is that ASCs, if they do the same procedure with the same type of patient in a hospital, that they get paid by Medicare maybe 53% of what the hospital does. So wasn't that reason that the federal government paid them so much less for the same procedure is because of all that backup that you are both required or have chosen to, you certainly have an ER. I thought that was just one effort. Am I right in that about the 53 ballpark?
To the best of my knowledge, you are correct. The facilities do cost cheaper to have it done.
So that's, and I hope you understand our goal in some of this too, 100%. Is that when it can be done for half the price, we represent the hospitals. I mean, not represent the hospitals, but we care about the hospitals as an employer, as a crucial part of a full, thriving community. But cost and affordability, our healthcare access is one of our problems. And more of the consumers, the patients in Georgia, don't really have enough money to afford their premiums anymore or their co-pays. So when we start looking at ways that we can cut the cost of a procedure in half, we want to at least, we feel like it's our obligation on behalf of not the people like me who's integral in a hospital, but the people who are consumers out there, the families that can't pay for their copay or their premiums. We have to be making some steps. And so I do know that the requirement for indigent care or a significant penalty was something Chairman Hatchett put in there so that somebody couldn't come in without helping with that indigent care burden. I hope you understand we're trying to imagine we were in your place. I know that's my role on the committee. I've been chief of staff of our hospital. It is a crucial thing to do, but I appreciate you being here. I hope you appreciate what we're trying to do on both affordability and protecting.
We do.
Thank you.
Okay, one other question, and I have it. And this is not directed at y'all primarily. But we have been part of this process for close to a year now. And unfortunately, all the groups have come up and said, you know, we would like to be part of the process in developing this law. Well, the process, like I said, has been going on over a year. So if y'all did not know the process was being looked at until this bill dropped, then that's a failure on the people who represent you here. You know, I have an issue with all of a sudden, and we had a 3-hour hearing the other day, and practically every person here who represented a hospital said, you know, we'd like to participate in the process. Well, the process has been going on for a year. So, like I said, undoubtedly the people who are representing you did not tell you so that you could participate in the process. Okay, thank y'all. Oh, one other question. Y'all mentioned work with the county jail.
Yes, sir.
I know that's a tremendous problem in most counties that have a jail. Does the county provide y'all any supplement toward that, or how are you compensated for work in the jail?
I don't know the answer to that question, how the compensation is done. I know that we provide the physicians and the care to go in or bring them out to the physician. I don't know what the compensation rate is.
Okay.
But I can find out.
I do know that
Mr. Chairman, we can find that out for you.
Yes, and I do know the physician who handles the jail is compensated by the county
Okay.
separately.
Okay.
So
Very
him
good.
at least.
Okay, very good. Well, that completes those who want to speak on. Yes, sir. Okay, hold on one second. Okay, go ahead.
Thank you. I'd just like a quick follow-up. Is it all three of your positions that you didn't know the Rural Economic Development Council had talked about certificate of need?
Not until the last few months.
Not until when?
Are you saying, were we aware of the situation over the last few years that this is?
No.
No, did you know
Did
that
you-
we were discussing CON changes before the bill was dropped, and if so, how far in advance?
We became actively involved in discussions at the board level and at the med-exec level probably about a month before it was dropped.
Right.
We invited our local representatives down to come and speak with us and sit at the table with us, and we asked them, what is your intent, what is your purpose? That's when it became, we had a face-to-face discussion, which was very profitable for us, and that's kind of got us fired up.
So back in the fall, you didn't know?
Right.
No.
Okay.
Okay, thank y'all. Okay, one other question. Oh, okay.
Thank you, Mr. Chairman, and thank you for your presentation this
Oh,
morning.
by the way, this is Representative Bentley.
Representative Bentley but thank you for your presentation. And I just want a quick question regarding county jails. I've been in some discussion about local jails shackling pregnant women, and I'm just curious to know, have you seen any of that in your hospital? Any pregnant women from local jails being brought in that were in shackles or handcuffs?
Not to my knowledge.
Not to my knowledge, no, ma'am.
Okay. All right. I just wanted to ask that, but I thank you again for your presentation. Yes.
Thank you, ma'am. Okay, that concludes Representative or Chairman Hatchett. Now you'll be looking at LC 337778S. This is the substitute for House Bill 198, and the purpose of this part with Chairman Hatchett will be for him to go over the changes that have occurred since we met and had the 3-hour hearing. Chairman Hatchett.
Thank you, Chairman Smith, and I want to thank the groups that came and presented today. First item that I am going to mention, it's on page 50, lines 1769 through roughly 1779, and you heard both of our presenters this morning mention freestanding emergency departments. One is actually in the process of putting in a hospital with another emergency room, have gone through the CON process to get that done. The other was talking about having access through those entities. So what instead of, in the previous bill, did not allow freestanding EDs, this will, in this version of the bill, and starting on this line, it will allow for hospital-owned emergency departments. And then there are stipulations that CMS requires, and some of those are listed in those lines right there. You have specifics. 1769 through like 1779 is where all that's taking place. Page 59.
Excuse me a second, Chair.
Okay.
If anyone on the committee has a question about any of these changes, push your button so we'll know and I'll call on you. Go ahead.
Okay, page 59. Line 2115. We were approached by our largest charity care hospital in the state, Grady, who asked to be included and have the protection that we're allowing the hospitals and outside of the Metro Region 3 for the same type of protection. We're offering those outside of that, and that's what lines 2115 through 2120 do. They allow Grady that same 10-mile radius protection. Question?
Chairman Reinders.
Thank you. I have a question as it relates to on line 2116, has a payer mix greater than 75%. I guess my question is why not 65 or 95 or what? How did we come up with the 75%?
That is the calculation that Grady asked for. It comes, I think they're reimbursed, I don't know if somebody's here, 35% from the government and from the counties that support the hospital, and then their indigent charity care percentages are that high.
For further inquiry, I know that, and I can't remember the exact number, the 6%, things of this nature. And there's always been a thought of mine that goes, why are the hospitals have said we have winners and losers in the past. Some pay more, some pay less, this and that. And there's a part of me that goes, one hospital size, or the hardest thing we have to do up here is write language for one size fits all. That's the toughest thing we do. And there's a part of me that says a hospital in downtown Savannah, a 6% margin would be nothing compared to someone else who is doing a 35% or a 70%. And I would just hope as we continue this discussion that we look at that number to see if there's not a way to find a better potential mix than just Grady, because there are some hospitals that 2/3 of the births may be Medicaid births, for example, things of this nature, perhaps tied into a Medicaid rate per congressional district or something, just thinking outside the box. Thank you, Mr. Chairman.
Noted, thank you. Next change is page 61, line 2165 through 2170. One of our rural members brought to me this concern, and what this does is allows for a physician practicing that actually is an owner in an ambulatory surgery center, that they would get credit for the indigent and charity care that they do outside of the ambulatory surgery center in a hospital or another setting. They get credit for the indigent charity care that they do in these other settings at their ambulatory surgery center.
Another question. Representative Jones.
Chairman Hatchett, regarding line 2170, has an ownership interest, was there a consideration made in terms of a floor? So for instance, it could be 0.001% versus 10% or 20%, meaning does that have a material interest as opposed to any interest?
There certainly can be, and I'm not sure as to if there may be an actual requirement on them for that, but I will check that. That's a good question.
Thank you.
Thank you.
Representative Fry.
Thank you, Mr. Chair. Chairman Hatch, I'm trying to get my head around this. If the physician, would the credit count twice for the care center and the hospital that the physician was working in?
No, it's what the physician does.
Okay, so it wouldn't count for the hospital's indigent care. It would only count for the physician's indigent care, right, in reference to the surgery center?
Correct.
Okay, correct. Thank you.
The next change is on page 62. Starts at line 2204. The first change on 2204 is there were some questions when we're determining the constant and the defining what is indigent charity care. We are proposing to use the Medicare rate times 1.5. This verifies or elaborates a little more that it's the Medicare base allowable rate. And then line 2206 is another section that we're adding that allows for any new licensee, it allows them to take 15%, and this is worded charges, and I'll go to that, 15% of Medicaid charges toward their indigent and uncompensated and charity care in the indigent care calculations that we'll be making for their requirements that they have to make. That's kind of complicated, but so we're taking your Medicaid that you get paid for, we're giving you the ability to use that 15% of the Medicaid to go towards your indigent care requirements. Yes.
Representative Newton.
Thank you, Mr. Chairman. Is that Medicaid, is that in reference to the fact that Medicaid often doesn't meet the cost of the care, providing the care for a poor person? Or
Correct.
So that just gives them partial credit for that gap? Okay, thank you.
Okay, the next section, right under 2209. In regards to the indigent care penalties, if you don't reach the indigent care requirement, we are going to allow the 25 most needy hospitals on the rural hospital tax credit list. They will not be subject to any fines because they don't reach an indigent care requirement. So your most needy hospitals, we know they're still going to provide indigent care and Medicaid, but we hope that, so if they don't reach the indigent care requirement, they won't be required to pay the penalty. Okay, the next and the final change is on page 68, line 2424. This is part of the transparency portion, and there were some concerns with at least a couple of hospitals, and there are a couple amendments to this that I'm going to mention when I finish this. But on line 2424, because there's many transactions, many things going on at these different hospitals, the changes, we only need them to be documented at the end of the hospital's fiscal year, at the end of each fiscal year. So we're only going to ask for this information once a year. They don't have to keep updating it every time they change. And that will, if there's no questions on that, there's two amendments that I know I want to incorporate in another bill, a substitute that will be here Monday morning, and one of them is on this page, and it's the same, applies just like 2424, but at 2420 on the listing of property holdings and wanting the location and ID numbers. Those change throughout the year too, so we just want to know what that is at the end of the fiscal year. And the other amendment that I would like to make is back on page 62.
Okay, let's go ahead and do the 2420, and that amendment to this bill adds where the semicolon is at the end of each fiscal year. Is that correct?
Correct.
Okay, got a move in a second. Do I hear? Okay, all in favor say aye.
Aye.
All opposed, like sign. Very good, thank you. Okay, where's the next amendment?
It's line 2206 on page 62.
Okay.
Where we are giving the credit for the Medicaid dollars in the indigent care. On line 2206, it reads that licensee may include up to 15% of its Medicaid charges. I would like for charges to be changed to payments.
Is that a form of motion? You want to explain why?
Payments are what the money that the entities actually receive. Charges are what they submit. So we know those are different.
Okay. All right. Is there a motion to add that amendment? So, second? Okay. All in favor say aye. All right, thank you. Those changes will be incorporated into a new sub, so you can't add an amendment to a sub, so you got to combine them. Found that out the other day. Okay. So the plan now, since we've got the bill has been gone through and all the changes have been recommended and all the amendments have been added and approved, we'll get a new substitute. Chairman Hatchett, when do you plan to have those? Well, let me ask the Legislative Council, when do you plan to have those ready? Okay, so right after lunch, the new substitute will be ready, and I guess you can probably stop by. Where you have the?
We could email it to everybody if that's okay, or we can get copies too. However,
so you know,
the pleasure of the committee.
The changes that were put on, you could pencil them in, and then you'll know that's the only changes that'll be done for next Monday. So, okay, well that concludes the part of the program where we have some hearings and also the changes in the legislation. I would like to encourage you to remember, you may get some calls from Chicken Little this weekend, that the sky is falling. Not necessarily true, but and like I said earlier, the meeting Monday morning is mandatory. Anyone who's not here, unless you have a really good excuse, you'll be removed from this committee for all other legislation that we've got for the next 2 years. So saying that, meeting's adjourned, and we'll see you in session.
All we hear from is the hospital. Somebody's got to speak up for that family that can't figure out how to pay their